Hello, everyone, and welcome to week number 15 of Anesthesia and Critical Care Refresher course under Saving Lives Academy. Uh, just two notes here. All the previous lectures are available, continuously updated on regular basis on the Academy's website, savinglivesacademy.com, and on the YouTube channel as well. Please remember to evaluate the course and feed us back with how to improve our course from the link I will post inside the Zoom webinar, as this how we continuously improve the course. Tonight, we have two highly selected topics that are not only clinically relevant topics, but appears frequently as well in most of anesthesia and critical care exams. The first topic will be presented by Professor Donald Buggy, and he is the first non-Egyptian speaker in this course, and he will talk about perioperative management of diabetes patients, which is an essential to learn for every anesthetist and intensivist. Second lecture will be on thyroid and adrenal emergencies as the two commonest endocrine emergencies. Prof. Donald Buggy, if you start sharing your lecture, please, while I'm introducing yourself. So, Professor Donald Buggy, I have the honor and pleasure to work with him in Mater University Hospital. He is a full professor of anesthesia and intensive care and perioperative medicine at the Mater University Hospital. He's graduated from the School of Medicine, University College of Dublin in Ireland. Professor Donald Buggy was an editorial board member in the British Journal of Anaesthesia since 2009 and 2010. He is a member of the European Society of Anesthesiology Research Committee from 2015 up till 2019. Plus, he's a chairman of multiple research groups, including European Society of Anesthesia Oncology Anesthesiology Research Group and EU Cost Action Euro. Periscope, and multiple other committees. So Professor Donald Buggy's main interest in research is oncology in anesthesia and diabetes in anesthesiology. So Professor Donald will talk tonight about diabetes patient and moped study. Please, Professor, go ahead. Thanks very much for coming tonight. I know how precious is presenting on Saturday night, so my full appreciation for your presence with us tonight. Thanks very much.
Thank you, Walid, and Massa El Khair. Massa El Khair, good evening, everybody. And I'm very honored by Walid's kind invitation to contribute something to your esteemed CEPD program this evening. And the title, as he has said, is Perioperative Management of the Diabetic Patient, and a brief mention of the moped study. So what I would hope to do in the next 30 minutes is to summarize everything we need to know about the perioperative management of the diabetic patient for now. And I say for now because, of course, the evidence changes as we get better evidence-based medicine. But for now, I believe this is an up-to-date summary of what I think you and I need to know to look after diabetic patients perioperatively. So here we go. Yeah, if I can get just bear with me while I get my screen to advance. Here we go. So in summary, what we'll do is revise the diabetes pathophysiology and a little bit about the drugs, the pharmacology of diabetes medication, speak about the periop management of the diabetic patient in the context of emergency or major surgery, and indeed also a word about type 2 diabetes in more minor or moderate surgery. To speak about the management of the diabetic ketoacidosis patient, and mention some abbreviations, this idea of a subcutaneous insulin infusion, a variable rate IV insulin infusion, and a fixed rate IV insulin infusion, which can look confusing when you write them down, but actually are very simple concepts. So just in summary then, to start off with a summary, the principles are, number one, involve the patient. So where possible, patients know as much or a lot about how to look after their condition as we do. And it's very useful to ask them how good their own control is, what their glucose values they've been recording in their own glucose control recently, and how they might manage skipped meals or past anesthesia and surgery. And if in fact their control is good and they're undergoing elective surgery, the first thing to say is to do not switch off all their insulin. In the past, some of us learned to, if the patients are fasting, we should switch off all insulin, stop all oral hypoglycemic drugs. And this seems to have been a mistake. So the current advice is to look at the long-acting insulin and give them about 70% of it. So for example, if a patient was on 20 international units of a long-acting insulin, we would say give them 14. Sometimes they would take their long-acting insulin at night, the night before your surgery, and sometimes it's taken in the morning. So reduce the long-acting insulin to 70%, but stop the short-acting insulin. And of course, the goal of the perioperative period, apart from looking after them during their surgery, is to promote early resumption of their own normal diet and diabetic medication. And if the patient is on metformin, the one specific oral hypoglycemic agent in type 2 diabetes, keep them on it. And we'll say why in a few moments. And in the emergency setting, begin resuscitation, as you would always do, I'm sure, in parallel with the first assessment. So the sick diabetic patient coming for a laparotomy, for example, we're going to assess the patient and what's wrong with their abdomen and how they are generally, but we're also going to instigate treatment at the same time. And that'll involve 2 cannulae, one dedicated to fluid resuscitation, for example, a balanced salt solution like Hartmann's, and the other for a glucose-containing solution, if necessary, like, for example, solution 18, mixed with, or at least with a separate attachment, a Y attachment, as we say here, for insulin. Obviously, a key to managing a diabetic patient perioperatively is keeping tight control, and that simply means checking it regularly, keeping the glucose ideally between 6 and 10, or at the very least between 4 and 12. And when the patients are unstable with high glucose values, meaning, more than 12, more than 20, sometimes higher than that, then it's worth measuring actual ketone values, which can again be done by a capillary blood sample. It's the worry with insulin infusions, such as a variable rate insulin infusion, is that it's easy to go wrong with them. It's easy to go wrong in preparing them. It's easy to go wrong in the ongoing management of them. So therefore, the advice is to use variable rate insulin infusions only when they are under our direct control, intraoperatively or in the post-anesthesia care unit, or of course, in a high dependency intensive care unit setting. On the ward, we need to think of something else. So the example of the kind of premix solutions we have is a solution, we call it solution 18 here. Internationally, I'm sure it would be 4% glucose with 0.18% saline, with premixed potassium KCl. And if the patient has a very high glucose, so for example, if you were dealing with a DKA patient with a glucose of 50 and high ketones as well, then obviously we don't want to give them more glucose intravenously until their glucose comes down. So that might use something like half 0.45% saline with added potassium. And having the added potassium is important because so many errors, fatal errors, have happened with potassium and insulin mixtures. And we've said how important it is to monitor it hourly. And of course, then, if the patient's very sick, they need to go to a highly monitored post-operative care environment. Okay, and then when we're moving away from it, we need to think of something else when we're moving away from the high monitoring environment. So just very quickly go back to the beginning. Classifying diabetes, really simple stuff. The most common metabolic disease, of course, it's characterized by hyperglycemia. In the UK, it's about 3 million people. In Ireland, it's about 200,000. It's about 5% of the population. And forgive me for my lack of knowledge. My last reading, Egypt must have close to 100 million inhabitants now. Would that mean there'd be about 5 million diabetics or potential diabetic patients in Egypt? So it's a common problem. And as you know, type 1 is an absolute lack of insulin. Type 2 is some insulin is present, or there's insulin resistance, but the patient makes endogenous insulin to some extent. And then, of course, there's gestational diabetes, there's maturity onset diabetes of the young, and of course, there's endocrinopathy. And I believe later this evening, you're going to discuss some of these other endocrine conditions. And then you can get diabetes secondary to pancreatic disease. So, of course, as we know, the insulin is produced in the Isles of Langerhans in the pancreas. And if the pancreas is diseased or destroyed, well, clearly there's a risk of secondary diabetes there. And just to revise the pathophysiology of diabetes, the problem, although we associate it with, of course, it's characterized by hyperglycemia, too much glucose in the blood. But the problem actually is that the cells are starved of glucose. There's no glucose or not enough glucose getting into cells. That's the problem, not really that the glucose we measure is 20 or above 10. The problem is it can't get into the cells. And so when insulin is plentiful and normal and it's going into cells, it will promote glucose uptake. It will promote the breakdown or the use of that glucose to make the energy currency of the cell, which, as you know, is adenosine triphosphate. It'll promote the storage of excess glucose, which is glycogen, and it'll promote protein synthesis, building up. We speak of insulin as being an anabolic hormone. And it also promotes the uptake of important intracellular cations like potassium and phosphate. And the opposite then in diabetes, well, clearly there is in fact the breakdown of protein if we have a lack of insulin, called gluconeogenesis, which means that our muscle tissues are being broken down to make glucose. If we can't make any or use the glucose that's outside the cell, we tend to break down any protein reserves we have. We break down our fats to make free fatty acids, and these combine to form things like alpha ketoglutarate acid, and beta hydroxybutyric acid, which of course are the keto acids, which leak out from the cells then into the tissue and cause a metabolic acidosis, which is very detrimental. And of course, if we don't have any glucose inside cells, well, then we start to break down any glycogen we have and we can't use the glucose. So all these adverse things happen without glucose. The good things happen, all these adverse things happen without insulin, and insulin does all these good things. And then in the setting of when it gets out of control, those same processes get out of control, a patient can get diabetic ketoacidosis, which is a triad of three things: hyperglycemia, ketoacidosis, and generalized acidemia, in other words, usually lactic acidosis. So hyperglycemia, lactic acidosis, and ketoacidosis. And just to think how all that happens, once again, if we've no insulin, all the opposite, so many hormones are the opposite to insulin that mobilize glucose reserves, such as growth hormone and the glucocorticoids and the catecholamines, and they're unopposed if there's no insulin. And so there's a tendency towards hyperglycemia and a tendency towards, inside the cells, a breakdown of fat. Can't utilize the glucose because it's not getting into the cells. We break down fat, we break down protein, we break down glycogen, we get increased free fatty acids to the liver. That in itself promotes gluconeogenesis. Gluconeogenesis means amino acids converted to glucose, which breaks down protein, of course. All of this glucose then is mobilized, and there's hyperglycemia. And then if the patient is taking glucose and not able to push it into their own cells, there's hyperglycemia. Meanwhile, the free fatty acids are making those keto acids. They're pouring out into the plasma, giving ketoacidosis. And then the mechanism of lactic acidosis very often is down to hypovolemia, because if there's all this hyperglycemia and all these keto acids, well, then these are extra molecules having an osmotic effect in the plasma. And if they have an osmotic effect in the plasma, they'll go into the urine, then glomerular filtrate into the urine, and they will draw water with them, causing polyuria, and an inability to reabsorb that water will cause a relative degree of dehydration. The dehydration will lead to decreased perfusion of cells, giving a lactic acidosis to add to the ketoacidosis. And diabetic ketoacidosis, as we know, is a medical emergency. So why is there a higher morbidity and mortality in diabetes? Well, we know that these patients have increased comorbidity. The way I remember what comorbidity is the little mnemonic knives. So they get kidney or nephropathy, they get neuropathy, typically glove and stocking numbness of the hands and feet. They get increased incidence of infection risk because of impairment of neutrophils in particular. They get vascular disease, and the vascular disease can be coronary, it can be cerebral, giving them an increased risk of stroke, and it can be peripheral vascular disease. It affects their eyes, giving them retinopathy, and it can affect the skin. And it seems that all this hyperglycemia glycemia, and sometimes hypoglycemia, if it's poorly treated, can be somehow, we don't quite know why or how, is associated with increased post-operative metabolic, infective and thrombotic complications. And there's an increased risk of post-operative infection. We've mentioned that seems to be due to impairing neutrophil function. And the risk of diabetic ketoacidosis is high among type 1 diabetic patients while they're in hospital, because they're often starved for surgery or for other procedures. And it's easy to get insulin wrong, even with the best attention in the world. We often delegate this to nursing colleagues or other medical colleagues, and it's easy to get it wrong if you're tired in the middle of the night, for example. And they're often on lots of drugs because of all these conditions. And sometimes we in anesthesiology don't insist on our diabetic patients being early on the list to reduce fasting time. So let's have a think about the medication we use to deal with, to look after diabetic patients. And of course, the most important one is insulin, needed for, well, usually for type 1 diabetics with no intrinsic insulin activity, but of course, type 2 diabetic patients often need insulin if oral hypoglycemic control is inadequate. And in simple terms, endogenous insulin is a peptide produced, of course, we know, by the beta cells. We can give external genetically engineered human insulin, and it can be classified in simple terms according to duration, short-acting and intermediate long-acting. We'd say, for simple terms, short-acting and long-acting. The short-acting stuff will onset within about 15 minutes and will last for up to 4 hours. The long-acting stuff can take up to 2 hours to get there and can last for, well, 12 to 24 hours, depending on the exact type. And of course, they're often given as a mixture of short and long-acting. And some of the regimens we can just think about, and it's just easier to think about the regimens if we look at a couple of simple graphs. So up at the top here, if you could just have a quick look at the top graph first. Well, this is how a long-acting insulin works, as you can imagine. The patient gives themselves an insulin dose at maybe this time of night, and it will last for almost 24 hours, giving a steady release of insulin activity with a steady background until the dose is used up by maybe this time tomorrow night. Very straightforward. And then in many cases, that's not enough because, of course, during the day, the patient has meals, and the meals are associated with a surge in glucose postprandially after eating. And so in addition to the background glucose level, maybe depicted by the blue here, the long-acting insulin, they would often need a short-acting insulin. And sometimes this can be done twice a day, just after breakfast and maybe just after the evening meal. And then in many cases, there is an additional bolus dose whereby they get an insulin dose 3 times a day or after each meal. So long-acting twice daily, and the so-called basal bolus with 1 long-acting dose, as we've said, and then 3 short-acting doses around the time of meals. And increasingly now, there is this continuous ambulatory subcutaneous insulin infusion. And it's maybe a long name, but a very simple concept, recommended in the UK for the type 1 diabetics. And all it is it's short-acting insulin pump that the patient has attached under the skin of their abdomen usually, and a little box, something like a mobile phone that they can carry about with them, strapped to the wrist or whatever. And they give a fixed hourly rate of short-acting insulin. So the patient has a basal hourly rate of, we'd say, 2 or 3 units of a short-acting, say, act rapid insulin. And if they're about to have a meal, they then give themselves, they dial up an extra 3 or 4 units, which they get to know how much they need based on exactly what foods they're going to eat and what the carbohydrate load of a given meal or a given foodstuff might be. And the tuned in young diabetics are very good at this. And of course, it may be changed hourly by the patient. If they know they're going to skip a meal or be late for a meal, well, then they don't give themselves that bolus and might even scale back the baseline hourly rate. And they're trying to control the glucose levels, keep it between 6 and 10, as we've said, but the outside acceptable range is 4 to 12. And then, of course, you're familiar with HB, basically glycosylated hemoglobin A1C, which, as you know, is a measure of the longer-term control of blood glucose I learned it as a good value is less than 8.5%. Now in standard international units, the ideal number is less than 69 millimoles per millimole. But many diabetic patients achieve a value a good bit below that. And so we would ask people in the perioperative period maybe to stop the short-acting insulin so that we can control it if they're coming down to us. So some rules for administering insulin, and this comes very strongly from the National Health Service in the UK and indeed in ourselves in Ireland and elsewhere around the world, and no doubt with your good selves in Egypt. It's easy to go wrong with insulin, even with our best attention. It's easy to cause harm by giving, for example, too much insulin or maybe too little, and they're trying to eliminate it in the UK NHS. So it should be prescribed by its brand name and not its generic name. And in this, I have to break my own rules. We should write down the name that the company, the manufacturer, gives us, ActRabbit, and not just short-acting insulin, to avoid confusion. And then to write out, very clearly the time and dose of administration. And we should have another colleague with us to check that we're not making a mistake when we're rushing or when we're under pressure. And as you know, insulin comes in a very concentrated vial. So, there can be 100 units in a mil. And to give something like 5 or 6 units involves giving a fraction of 1 ml, which requires a particular tall, thin insulin syringe. We should always use that to try and get the dose right, mix it properly, and write out the words units and not anything else. So glucose-lowering drugs then, in brief, oral hypoglycemics. Metformin is the most important one. So can I mention this first? We mentioned sulfonylureas to dismiss them. There's intestinal alpha-glucosidase inhibitors. There's the new sodium glucose transport 2 inhibitors. There's glucagon-like peptide analogs, and there's these dipeptidyl peptidase inhibitors. So metformin. If I've presented poorly, this would be the one slide to wake up for. It's first-line treatment in type 2 diabetic patients, and it actually has been one of the few agents which improves cardiovascular outcomes. They get less heart attacks, less strokes, less peripheral vascular disease on it if they take it regularly. It does require the patient of some residual insulin. And how does it work? It works in the liver to activate the enzyme AMP kinase to stop gluconeogenesis. So it stops breakdown of protein, which is important because as we get older, especially, we work hard for our muscle tissue. And by aging alone, it tends to diminish by 1% per annum. It inhibits glucagon, which of course is an antagonist of insulin, which tends to mobilize excessive glucose reserves. And it inhibits excessive absorption of glucose from the intestine, which means we don't get so much hyperglycemia. And perhaps most importantly of all, it increases the sensitivity of the endogenous insulin by increasing insulin receptor expression in muscle tissue, in fat tissue, which means that the insulin they have will work a bit more effectively. And we grew up with learning, don't give it because they might get lactic acidosis. It turns out that in evidence-based medicine, the truth is very rarely do people get lactic acidosis on metformin. It's only a risk factor when patients are in end-stage renal failure on dialysis. And even then, metformin can be used cautiously if you're watching out for the lactic acidosis. The main message is that metformin prevents glucose from increasing. It won't cause hypoglycemia. So if a type 2 diabetic patient is on metformin, keep them on it, even if they're fasting, even if the list goes wrong and they're fasting for 24 hours. They won't get dangerously hypoglycemic on metformin, but it will hopefully control hyperglycemia for us and for the patient. Sulfonylureas are out of date. They bound sulfonylurea receptors. They squeeze out insulin vesicles, and long half-life and renal excretion, again, avoided in renal failure. And really, its use is fading. Don't worry about them. Intestinal alpha-glucosidase inhibitors are out there. An example would be acarbose. What's going on? There's an alpha-glucosidase in our gut mucosa, which breaks up disaccharidase. Disaccharidase just means two glucose molecules stuck together. So we need this alpha glucosidase to break down, dissect these double glucose molecules so that the glucose can be absorbed. And of course, if we inhibit that enzyme, well, then the double glucose molecules won't be absorbed, which means we get a bit less glucose from the gut. So it helps. Similar concept acting in the kidney is these SGL2 inhibitors, sodium glucose transporter 2 inhibitors. Canagliflozin is an example. So as we know, most of our plasma volume is filtered every day through our glomerular filtrate, and it's reabsorbed again. 99% is reabsorbed again in our proximal convoluted tubules by these SGL2 transporters. And inhibiting this causes certain osmotic diuresis, which can help control, and with the diuresis, of course, is a reduced glucose level, which can help long-term glycemic control. But it turns out that there's growing concern that if we continue these molecules in the perioperative period or during any other period of starvation for the patients can get diabetic ketoacidosis because it causes so much dehydration, so much lack of glucose to be around. It can actually cause that pathophysiological, I suppose, pathway that we mentioned in the earlier slide to get activated. So a good idea to stop these SGL2 inhibitors just in case. And then there's glycogen-like peptide analogues, the example being exenatide. They're encretin hormones. They're secreted from the gut mucosa in these L cells, and they reduce gastric emptying and so slow the rate of glucose increase, which is good, especially for patients who have some residual insulin, and they promote satiety, which simply means a feeling of fullness, so the patient isn't going to go off and have another glucose meal. Glycogen-like peptide analogues is a bad name because, as we've said earlier, glycogen is the hormone which opposes insulin. But in fact, confusingly, glycogen-like peptides actually have an insulin-like effect. They look like glycogen in their molecular structure, but actually they work a bit like insulin. They're not insulin, of course, but they have similar positive effects to insulin. So isn't it terribly confusing that they gave it the name glycogen-like peptide? So it's a goodie. We want glycogen-like peptide. Turns out that type 2 diabetics have lower levels than normal, and that its half-life is very short once it's released from the gut mucosa into the circulation. And it's metabolized by one of our own enzymes, dipeptidyl peptidase. So if you can look at this graphic, this glycogen-like peptide, which is really like insulin, exenatide, is missing or is deficient a bit in type 2 diabetic patients. And they do these good things. So we want to increase its active level. And one way to do that would be to either give something that looks like it, like exenatide, a tablet which has a similar effect, or to stop the breakdown of the glycogen-like peptide one that we already have. So we break down its inhibitor, this dipeptidyl peptidase inhibitor. If we give something like sitagliptin is a DPP4 inhibitor, which means it inhibits the inhibitor, if you follow me. It stops the breakdown of this glycogen-like peptide, which means it can do its beneficial thing. I hope that slide makes it a little bit easier. All we're saying is that glycogen-like peptide, or exenatide, it's exogenous, it's tablet medication, has insulin-like effects which are beneficial. So we can either give the exenatide or give the thing that prevents the breakdown of our own endogenous GLP molecule. So what about the diabetic patient for emergency surgery? Well, of course, we have to do preoperative assessment, and of course, we have to do airway breathing circulation. Now, these patients often aren't unconscious, or at least if they are, they're in really a very critical state, but they will all benefit from simple things like supplemental oxygen immediately while we get intravenous access. And of course, we assess the urgency for surgery. Very often these patients will need, for example, an emergency laparotomy for some reason, or they may indeed have necrotizing fasciitis and need a debriding of that. And we need to try and get some handle from their history or a collateral history from their relatives, or the medical notes about what's going on for them in terms of their comorbidities, and importantly, what their glucose control has been recently. Have they been ketotic? That means ketone values above 3. We want to see the ketones less than 3, the normal values less than 1. And what has their long-term glycemic control been like? What's their HbA1c been like? Has it been less than 69 for good control, or has it been worse than that? And if they're going to miss one meal or have already missed one meal or more than that because they're vomiting, they will need an insulin infusion. Otherwise, there's a risk that ketones will accumulate. So you need to think about giving them a variable rate IV insulin infusion. And if you're going to do that, you need to give them a drip, an infusion which has a bit of glucose in it, unless their glucose measurement is gone mad, is off the scale. So we would expect that if they're an unstable type 1 diabetic, that their glucose will be above 12, it might be above 20. But if it's gone mad, like DKA mad, and by that I mean above 30 millimoles per litre, well, then they don't need us to give them glucose. And I suggest that we provide resuscitation and maintenance fluids separately. So maybe I can illustrate that here. So look, it doesn't have to be like this, but in our drawers, we have this Y-shaped attachment. So all it is, we put up our cannula, 18 gauge, 16 gauge. And this Y attachment simply means we can infuse 2 things at once. And what I use it for is, one is for a glucose containing solution. This is assuming that the patient's blood glucose is needing control. So it is perhaps in the range of 4 to 12, and indeed it may be higher than that, but not DKA. So we're saying that the patient has a blood glucose under 30, and sometimes even within the normal range. And we will attach a glucose containing solution to this. We use this one I mentioned earlier, glucose 4%, 0.18% saline with added potassium. And in the other side of the Y, can't get my cursor over there, on the other side of the Y, we would simply give the insulin infusion. So that means that the two go in together. If the drip fails, for some reason, the drip tissues, the patient doesn't get the insulin and they don't get the glucose, and they don't get both at the same time. What you don't want is them getting the glucose and not getting the insulin, or vice versa. And then I would put up a separate cannula over here for the Hartmann solution or the resuscitation fluid. That's all I'm saying. Now, if you want to put up 2 separate cannulae, one for the glucose, one for the insulin, and another one for the Hartmanns, that's okay too. But just suggesting this as a possibility if you can get hold of some little attachment like this. Okay. The insulin infusion, of course, as you know, consists of 50 units of short-acting insulin in 50 mils of saline. So simple as it sounds, it's easy to make a mistake, and tragedies have happened because of errors around that. So it's important that 2 persons are willing to sign that drug preparation. So it's 50 mils of saline in a big 50 mil syringe, and then add the tiny little bit of 50 units of Act Rapid, would typically be half a mil or less, so a very small amount of Act Rapid added to the big solution. And then, of course, you have 1 unit of insulin per mil, and you can dial up then whatever your judgment indicates might be a reasonable hourly level of insulin to keep that glucose value between 6 and 10. So when would you use a variable rate IV insulin infusion? Well, type 1 diabetic patients missing more than 1 meal, or a poorly controlled type 2 diabetic patient, or if they're unable to tolerate diet, like if a diabetic patient is vomiting or got GI disease for whatever reason, or severe systemic illness that they can't tolerate a normal enteral diet. And we shouldn't delay it. So that means we try to get the patient down first or second on our list if we can. And we don't do that often enough. That includes me. Sometimes we don't hear about a diabetic patient. It's not a priority for our surgical colleagues. We don't flag, or none of us flag our diabetic patients, or we don't create systems that enable diabetes to be alerted to us by our colleagues often enough in my hospital. And the worry is that a lack of insulin, if we've asked the patient to take less, now hopefully, as we've said earlier, we've asked the patient to take 70% of their normal long-acting insulin as a kind of a protector against, organizational issues leading to a failure to give it. But, if there's a complete lack of insulin, or even if the amount of insulin is inadequate, there is a risk of getting this DKA, and it can begin to happen within an hour. So once again, we put up the insulin and the substrate fluid. By that I mean the fluid that has a bit of glucose in it in a dedicated cannula. We have a separate one for the Hartmann solution or balanced salt solution. And we should try and keep the glucose and insulin infusion going even when we're transporting the patient. Okay. And the variable rate, what we have to say is that, audits have shown that the variable rate IV insulin is associated with bad effects if it's not monitored. That means monitored hourly, and then somebody not just monitoring the numbers, but actually doing something about it. So if I have a patient on an IV insulin infusion with the guy started off with a glucose of 10, and 1 hour later the glucose has come down to 4, well, I need to reduce my IV insulin infusion level. I need to do something about it. And of course, we mustn't forget that the insulin will not just push glucose into cells, but it will also push potassium into cells. So we have to watch out for hypokalemia. And the simplest way to do that is to measure it. Hourly blood glucose check, and maybe if you're worried about it, you might also send a blood gas machine. Our blood gas monitors give us a potassium value, or simply send off an arterial blood gas monitor every hour or so if you're worried about it. Okay, if the blood glucose is going low, the message is don't completely stop the insulin, but reduce it maybe to 1 unit an hour. And if you are worried about hypoglycemia, well, then maybe give a small amount, say a 100 ml bag of glucose 5%, and recheck in 5 minutes. That should be enough to get the glucose back up again. What substrate fluid do I mean? We've said that it's necessary that insulin drives glucose and indeed potassium into cells. It also drives potassium into cells. So this is what we use, but no doubt you have your own. The idea is that if the glucose is within the normal range, or even if it's out to 20, 25, we still need to give a solution that has a bit of dextrose in it, because when we start giving insulin, it will come down. And then the Hartmann solution is for maintenance fluid and replacement fluid by a separate IV cannula. Now, what if the patient is one of these subcutaneous ambulatory infusion pumps that we mentioned earlier? Well, same concept. We establish our separate fluid IV, and we'd ask them to keep their pump going until they come down to you in the induction room, right into the induction room, and then we'd ask them to switch it off, because then we're going to take over control with our variable rate IV insulin infusion. And of course, the key to all of this is the hourly capillary blood glucose checks, or nowadays, in fact, increasing numbers of patients are coming in with these external cutaneous devices, typically located on their deltoid region of their upper arm, whereby simply a touch technique with their own mobile phone can enable them to get an immediate glucose check, almost a continuous, or a glucose check that can be delivered to them without pricking the skin. And perhaps we can, with their permission, use that intraoperatively. So we stop it just before induction of general anesthesia and then take it over while they're under our control in the operation room, or indeed in the post-op care unit. Okay, what about the DKA patient? They sometimes present with necrotizing fasciitis or other emergencies. They break their legs, they have accidents, they have acute abdomens. We've said it's a life-threatening condition characterized by the triad of ketonemia above 3, hyperglycemia above 12, metabolic acidosis, as you know, is lactate above 2. And of course, we have to consider putting them, we really should be going to a HDU or ITU environment post-operatively. Of course, we assess ABC, give them supplemental oxygen, get the fluid resuscitation going, and get insulin therapy going. What fluid resuscitation? This is veering off course a little bit, but again, the suggestion is to use pre-mixed bags of pre-mixed potassium chloride, because again, we've all made mistakes trying to add potassium to saline. And even if we supervise the first one in the middle of the night, some poor nurse or some poor young colleague is going to be trying to do this in the middle of the night and can make a mistake where the potassium can lead to a lethal consequence. So we try to use pre-mixed saline and potassium mixtures for our maintenance fluids. And notice here the fluids that we're suggesting in a DKA patient, and in diabetic ketoacidosis, we're expecting the glucose to be very high. I mean above 30. And in those situations, we don't want to be giving a glucose-containing solution. Typically, we'd use half normal saline. Why half normal saline or half abnormal saline? Because, as you know, even so-called normal saline is hypernatremic, and these patients are often dehydrated for the mechanism we mentioned earlier. So we want to give them a hyponatremic solution to prevent them getting hypernatremic. And a typical, in my head anyway, 10 mils per kilo is a typical reasonable place to start if somebody's hypovolemic. So the 70 kilogram guy or woman gets 700 mils. The 50 kilogram little old lady gets 500 mils, and so on. And then reduce it or evaluate the response. Ongoing monitoring then in diabetic ketoacidosis, well, the suggestion is to use a fixed rate insulin infusion, a different acronym. Instead of being VRIII, it's FRIII, and that's a little bit unfortunate. It's the same insulin infusion, and all it is, a fixed rate insulin infusion is exactly the same as a variable rate insulin infusion. It simply means that you would decide on a dose of insulin for the hour, for example, 7 units per hour, 8 units per hour, 10 units per hour, and you'd keep it going for that hour and wouldn't change it. And then you'd revise it after checking the blood glucose. That's all it is. So the reason I mentioned fixed rate IV insulin infusion is not to confuse you, but because it's out there and it's equal to variable rate IV insulin infusion. It's just that you decide on the insulin rate for an hour, which I do anyway, and then I change it after I've checked the blood glucose at the end of that hour. With a severe diabetic ketoacidosis with a glucose of, say, 40, we set up our resuscitation fluid, our half normal saline, we set up our insulin infusion, and because their glucose is so high, we might like to give a bolus of insulin. And the typical suggested bolus is 0.1 of a unit per kilogram for that first hour. So again, the 70 kilogram patient will get 7 units of insulin as an actual push. You would get the machine, or maybe even to do it manually again, if somebody is with you to help you get it right, you would push the syringe from 50 mils down to 43 mils, give them the 7 mils as a bolus. Usually the infusions have a bolus function on it. And that helps to get the insulin on board quickly, get the glucose being pushed inside cells, and then dial up 7 units an hour for that first hour. And come back then at the end of that first hour, having given a total of 14 units of insulin, and see where you are. Has the glucose come down? And if it has come down to about, and they also suggest that we should be measuring the ketones, because remember, in diabetic ketoacidosis, yes, we have hyperglycemia, but actually the biggest problem is the ketonemia. It's the ketones are above 3. And that's what's causing all the metabolic and systemic damage. So you would hope to see the ketones coming down with this aggressive insulin therapy. And what they warn us about is that we should be aware of hypoglycemia may occur before we get the ketones down. So the big aim of giving the insulin infusion is, yes, it gets the glucose down, but the bigger aim is getting the ketones down, getting it down to 3. And it can happen that the glucose comes back towards normal first. And if the glucose is within the normal range, but the ketones remain above 3, we need to still keep giving insulin. So what do we do then? So when the glucose level comes back approaching the normal range, they say when it becomes less than 14, this is what's out there, not less than 12, we should switch to or add in a glucose-containing fluid, again, like solution 18, to make sure that the patient is getting some glucose so that the insulin will not cause hypoglycemia whilst it continues to work on the ketones. Okay, So once again, hourly then we're measuring the ketone value. We used to do this. I used to do this. I've only changed my practice in the last year. I ask for the little machine that measures the patient's glucose. I also ask for the little box that measures the patient's ketones. And of course, we should be checking for potassium and indeed serum lactate. These patients will often have a metabolic lactic acidosis as well, and they'll have a metabolic acidosis because of the keto acids. So we should be sending hourly blood glucose, hourly ketone values, which is new to me anyway, and of course, hourly blood gases. And we've said already that we would stop just to avoid confusion. You're in charge. You don't want yourself, if you're dialing up the insulin infusion now for the patient while they're under your care intraoperatively. So I would advise stopping, not disconnecting, but stopping the subcutaneous pump that might just confuse how much insulin they're actually getting. We switch it back on again once the patient is, I suppose, re-emerged from anesthesia and able to control it themselves. And of course, if necessary, we get some advice from the endocrine team. But actually, these are the guidelines. These are the guidelines for the perioperative period. The endocrine team will offer great advice for how to manage the thing going forward once they leave our care or leave our ICU unit. Now, in this part of the world, we use a glucose potassium insulin infusion sometimes, and it's useful essentially in the low monitoring setting. For example, in a ward setting where you and I don't control it directly, where we don't have nurses that we can trust to, where we don't have a lot of intense monitoring, where the patients will only be seen once every 4 hours, for example, to check their blood glucose. And here we have our premix bag of 4% glucose, 0.18% saline that we mentioned before, with our added potassium, as we mentioned before, the same bag of premixed stuff, to which we add in a dose of short-acting insulin, depending on how much insulin the patient is having. And this is where the endocrine guys, the diabetologists, might help us. They might give advice on whether you put in 8 or 12 units. But it's just insulin is added to this bag, and then we let it run at about 100 mils an hour, about maintenance fluid levels. And we hope that this keeps the glucose in some kind of shape, keeps the patient from getting ketotic while they're on a ward where the nursing staff can't get round to patients in a very intense way. And of course, we'd monitor the blood glucose as often as you can, but on these wards, the patient simply won't be seen hourly. In my ward, we're lucky if the glucose is measured 4 hourly. And then if the number is high, let's say the glucose is over 10, then there's a subcutaneous scale given whereby the nurse can then administer 1 or 2 or 4 units of rapid insulin subcutaneously if the glucose is above a certain value like 10. And it can be used on low monitoring wards where it's not too intense. And it'll work for type 2 diabetic patients who are fairly well controlled anyway, or in the patient who's been stabilized. I really will only briefly mention that in the ESA, the European Society of Anesthesiology, we've recently had approval to do essentially an audit, but we're calling it a prospective observational study of 5,000 diabetic patients to actually see what's happening and count or measure what happens to them at 30 days. You may say, isn't this done before? I thought it was until I read up on it. And in fact, there's relatively little known about how to measure or how to manage diabetic patients perioperatively. Yes, we've delivered everything I've just suggested to you. That's the current advice, but it's actually based on expert opinion rather than on hard evidence. And so what I want to do is lead, I suppose, the biggest epidemiological population study of diabetic patients to date to evaluate what are the different treatments or management of diabetic patients that people are doing, and how do the diabetic patients get on at 30 days, and see does anything we do intraoperatively affect that outcome. Our big, I suppose, measurement, our primary outcome measure is the number of days at home at 30 days, which is sensitive to postoperative complications, obviously to mortality, to readmissions to hospital, to admissions to nursing home, that kind of thing. We'll also measure their complications and something called the quality of recovery on day one. And we'll include any diabetic having any substantive anaesthetic technique except local anaesthetic. And we hope that it might make perioperative practice in diabetic patients better. It's very variable at the moment. So in summary, dear colleagues, we've said that we should ask the patient's opinion, how to manage perioperatively. We've suggested continuing the patient's subcutaneous infusion of short-acting insulin until the last minute, so to speak, until they come into our care directly in the operative area. We should continue their long-acting insulin at 70% of the usual dose. So don't stop the insulin, especially the long-acting insulin, completely. Tell them to take 70% of the usual dose the night before, or even if it is normal for them, the morning of. And of course, what we're looking for is a glucose between 6 and 10, but we'll tolerate 4 to 12. And to achieve that, we need to be doing hourly capillary blood glucose intraoperatively. If they're type 2 diabetics on metformin, keep them on it. It is safe, they won't get hypoglycemic. When they come under our care, intraoperatively, or maybe in our post-op care units, or of course in the ICU, we should get this variable rate insulin infusion going, 50 units of Actrapid in 50 mils of saline, checked between 2 colleagues, and then run typically at an hourly rate, depending on where the glucose is at, checked and revised hourly. And I'm suggesting that a Y cannula might be helpful for that. One part of the Y gets the insulin pump, and the other half gets the glucose-containing solution. But we have to be careful. We can't send the patients back to unmonitored wards or to poorly staffed wards with a variable rate IV insulin infusion. We have to do something else like the glucose, potassium, insulin, GKI infusion that we've just mentioned. And if they're seriously ill, diabetic ketoacidosis patients with glucose values off the scale, the first question we should always ask is, what's their ketone value? And you'll find it's a number above 3. That means the patient's critically ill. In this case, we might even give them a bolus of insulin, about 0.1 unit per kilogram. Maybe that might be 7 or 8 units of an actual push, followed by that for 1 hour. And then, of course, see how you're doing. Check the blood glucose hourly. And when the glucose is coming down, we shouldn't stop it, because glucose isn't our, if you like, our defining treatment. Getting the glucose down into the normal range is not the defining treatment for diabetic ketoacidotic patients. I thought that this was learning for me in the last year. It's getting the ketones down. And that's why we need to actually directly measure the ketones. And until those ketones are less than 3, we have to keep giving the insulin. And even when the ketones are less than 3, we still have to give a basal level of insulin, even if it's only 1 or 2 units an hour. So be ready to reintroduce a bit of glucose when the glucose is coming down. Okay, and all I can say is thank you so much for listening. I'm sorry for going on so long. And once again, Massa Elkir.
Thanks very much, Prof. Donald, for this very comprehensive lecture. I myself watched you teaching this lecture before, but I wanted to deliver the message to our 250 colleagues sitting watching here. So thanks again for coming on Saturday night, teaching us today or tonight on the DKA. So one question by Professor Magdi Khalil. It looks that he had a technical problem, but I know the question from before the lecture. He's asking, in our pre-op assessment for surgery, what's the hemoglobin A1C cutoff sign or cutoff measure that we can accept for a patient coming for an elective surgery? Is there any cutoff if the patient has hemoglobin A1C that's very high? Is that an indication to postpone the surgery for 3 months until I get the good number?
Oh, thank you. Super question. It depends on how elective the surgery is, I suppose. So yes, if it's purely elective surgery, that can wait, and the HbA1c is very high. If it's close to, well, we're using this number 69 millimoles per millimole. If it's above, if it's above 80, if it's way above normal, and it's clear to you from the history, or indeed from a collateral history from a relative, that the patient isn't looking after themselves, isn't measuring their glucose regularly, then there's no doubt that poorly controlled glucose is an additional risk factor. Poorly controlled glycemic or poor glycemic control, glucose levels that are too high is an additional risk factor in the perioperative period. So your alert, your antennae are up if it's above the cutoff, the 69 millimoles per millimole or 8.5. There isn't a defined number out there, but if it's above 10, if it's above 80 millimoles per millimole, you have to be asking the patient what you're doing and explaining to them that you've got to get the glucose control tighter to reduce their own risk of bad stuff happening, all kinds of bad stuff happening, like infections and like further diabetic incidence in the post-operative period. So at that stage, especially if it's elective surgery, I'd be referring them to their diabetes consultant to ask them to get a better grip on this if it's truly elective. The difficulty arises that very often our patients have urgent surgery, for example, cancer surgery. Yes, you can defer that for a week or two, and it's worth tightening up the glucose control in a week. That can be done effectively, but we can't send a cancer patient away for 3 months. So it depends, I suppose, on how elective the surgery is.
Lovely. So there was a little bit maybe confusion, or this point was not clear from one of our attendees, Ali Saad, and he's asking, do we, in the term of variable rate infusions, do we keep that running intraoperatively plus the infusion that we use like GI or GKI intraoperatively, or we stop the variable rate pumps?
Super question. I'm so sorry for not being clear. No, one insulin infusion at a time would be a message I should. So GKI is only for the ward where there mightn't be much monitoring, where the best you can hope for is that somebody will take the glucose or look at the patient 4 hourly. When the patient comes down to us, once I get my variable rate IV insulin infusion going, I would stop the GKI immediately, because now, one thing at a time, this variable rate IV is directly intravenously, and you can hold the GKI. You needn't throw it out. In fact, the smarter thing to do is to put it aside and put it back up for the patient when they are returning to the ward. If the control is reasonably good preoperatively, but when they're under our control, just the variable rate IV insulin infusion is the optimum control, provided we're monitoring it, of course, every hour.
Perfect. So a question by Ismail Higazi. He's saying, if a patient is developing DKA with a brain edema, is there any special precautions to avoid this happening or treating the brain edema in a term of DKA? Thank you.
Goodness. The short answer is I don't think so, no. I'm not aware of any specific, I suppose, differences in the diabetic ketoacidosis management that we've summarized there in the case of patients with, as you said, cerebral edema, except that, of course, these patients are more likely to have impaired levels of consciousness and may need, when we say ABC of resuscitation, well, these patients may need their airway taken if the Glasgow Coma scale is down below, well, if they're clearly, delirious, confused, or even in various levels of unconsciousness, we may need to take over, ventilate these patients soon. Early on, and after that, then it's all about getting the standard DKA treatment based on fluid resuscitation, based on insulin, under control as quickly as possible.
Perfect. So it's almost 1 hour now, Prof. Donald, and I'd really thank you so much for your presence with us tonight and your comprehensive talk, and have a good weekend. So see you later.
Thank you.
You're free to go.
Thank you. My pleasure. And once again, Massa Healthcare. Thank you. God bless. Good evening to you. Thank you.
Thanks a million. Perfect. So we're going ahead now to do, first of all, the poll for, as you know, for documentation of your attendance here. So the poll is just gone now. You can feel free to start that. While I am presenting Prof. Salwa Al-Khattab, our second lecture speaker about. So she's talking tonight about thyroid and adrenal emergencies. Professor Khattab is Salwa El Khattab, sorry for that, is an assistant professor at the Department of Anesthesia and Intensive Care and Pain Medicine at Ain Shams University, and she is leading the Mirdash Surgical Intensive Care as well. So she's talking tonight about one of the most important topics that I myself had in my MD exam and in Arab board exam, and it came as well in the Irish Fellowship of Anesthesia. So 3 exams are like mentioning these type of questions or these topics. So please watch carefully, and Prof. Salwa, you can unmute yourself, please, and start sharing your presentation kindly.
Thank you, Dr. Walid. Good evening, everybody. Actually, Masa al Khair, same like Professor Baghi told us. I really, it was a very comprehensive and valuable lecture. I hope to start our lectures together. Tonight we will speak about, let us to start. Actually, the question is why we are taking from your time to cover these 2 topics. What is the importance of having a thyroid and adrenal emergencies in particular to speak about? It's not that much common to see a patient in either thyroid or adrenal hyper or hypofunctions coming in emergencies. Actually, they are uncommon or even rare, but they are fatal, and the mortality is still high for both of them, even with advancement of the diagnosis and treatment. The point is that it is a preventable mortality. That's why we have to diagnose to catch the patients suffering from either thyroid or adrenal emergencies in a proper time, so not to miss them. It is a preventable mortality. So let us to start. This is question to start about talking about our topic today. What is true about thyroid and adrenal emergencies? They are very common health problem. There is no age or sex discrimination. They are potentially fatal with high mortality rate. They are easy to diagnose due to clear, distinct symptoms and signs. What do you think?
Can you see the results, Prof. Salwa?
Yes. Most of answers coming, they are potentially fatal with high mortality rate. I agree totally with this one. So let us to proceed. In endocrine emergencies, usually there is a failure of some aspects of the complex system of hormones regulation and feedback loops, which represent the interaction between hypothalamus pituitary from one side and the site of hormone release from the other side. This failure, if not well treated and promptly treated, it might turn into a nightmare, especially in the presence of a triggers. Usually there is a trigger in this situation, and it will result in a life-threatening problem. The big problem here is there is a very big diagnostic dilemma. Diagnosis actually is not easy at all. You have to differentiate between a lot of causes which can mimic the same presentation. The management in ER and ICU is very important. So timely management, proper management, starting from ER and then continued in intensive care units is of great importance to prevent a deadly condition. So tonight we will cover thyroid emergencies, namely thyroid storm or myxedema coma, and also adrenal emergencies, acute Addisonian crisis, and pheochromocytoma. We will speak about definitions and background, the risk and triggers factors, clinical presentation, labs and radiological finding, and emergent management. To start with thyroid hyperfunction. Actually, thyroid hyperfunction is a state of hyper. It's exaggerated condition. This is a case, it's a real life case, 53 years old female patient presented to ER with acute onset of severe respiratory distress. She gave medical history of asthma and hypertension. She reported the chronic history of palpitation, anxiety, tremors, insomnia, heat intolerance. She also complained unintended body weight loss of 40 kg over the last 3 years. She gave no history about any thyroid illness or treatment. On examination, her vitals was like that: blood pressure 180 over 135, heart rate 150, respiratory rate 44, oxygen saturation 70 on room air with temperature 38.3. Physically, she had exophthalmos of both eyes, and there is a swelling in the neck, goiter, and there is a hand tremors. Here we can see the chest X-ray and her 12-lead ECG. Chest X-ray, there is a pulmonary edema with a sinus tachycardia in her 12-lead ECG. Of course, the patient intubated immediately in ER because of this hypoxia, respiratory failure, and respiratory distress immediately, and connected to ventilator. And then she moved to ICU for further management. What we can see here is her blood gases, which showed actually respiratory acidosis, pH 7.17, and partial CO2 is 62.3 millimeter mercury. She's no more hypoxic after controlling her ventilation. Bicarb is okay. And this her labs, the labs results ordered later on in ICU. There is mild elevation in troponin, start 0.5, then 0.3, then 0.56. CK is not that much elevated. CKMB is also almost normal. And down we can see her thyroid profile. We can recognize a very, very, very low TSH and increasing both T3 and T4. To the right, her labs chemistry, almost, there is no much abnormality we can see. Almost okay, accepted. So further investigation requested in ICU is echocardiogram, and upon this very clear thyroid profile, the colleagues requested thyroid sonogram, and later on after thyroid scan was requested. Her echo show left ventricular ejection fraction 50%, normal left ventricular size, and nothing more. There is aneurysmal atrial septum. Thyroid sonogram, multinodular goiter with largest nodule 3.6, and thyroid scan revealed marked increase uptake at 4 and 24 hours, all suggestive of hyperthyroidism. So for this patient, it looks like we are facing, we are diagnosing now a state of hyperthyroidism, but which is very acute. Let us to have this question. Considering thyroid storm, I can tell all are true except it is potentially fatal. It needs urgent treatment in ER and ICU, ICU admission. We must identify and treat triggering factor. It is common in young male. What do you think?
Can you see results, Prof?
Yes, agreeing. It is common in female, of course. So what are the positive findings in this case? Actually, we are facing a patient with fever, with severe tachycardia. She's asthmatic with asthma exacerbation. There is a heart failure and pulmonary edema by auscultation. I forget to tell about auscultation, but also by chest X-ray. It looks like we are facing a non-STEMI. There is increasing thyroid hormone with suppressed TSH. So where we are, what runs in with the thyroid storm in this case? I can tell it's, she's having a suggestive history. It's only suggestive because having insomnia and anxiety, tremors, it might be an anxiety neurosis or any other, but it is very suggestive in this scenario. Having fever, high fever, having tachycardia might be out of proportion to this fever, and with this clear thyroid profile. Actually, we told we have to search about trigger. So what the trigger here? This patient is not diagnosed before. She denies any history of any diagnosis of thyroid, and of course there was no treatment. So this is her first presentation. She's the first time presented with this acute condition. Also, stress of being in acute asthma exacerbation might be a precipitating factor. What other diagnostic tools? Actually, there is two or more scoring system to identify and help to stratify thyroid storm. We might like to have a scoring system. Usually scores are sensitive, but they are not very much specific. Let us to have a look for this score, which is usually the one used. Actually, this is an overview about thyroid storm. It's a rare, like we told, life-threatening, again, high mortality. We have triggers, and we have a scoring system. This is Borsch and Bartovsky score for thyroid storm. It gives points for thermoregulatory dysfunction, for cardiovascular dysfunction, congestive heart failure, GIT and hepatic dysfunction, central nervous system disturbances, and also for the presence or absence of precipitating factor. A score of more than or equal 45 means we are in a storm. A score less than 25, it is unlikely to have a storm. Between 25 and 44, actually, we are approaching, we are impending storm, and we have to be very aggressive in treatment to avoid being in a storm. There is another scoring system. This is Japanese score. It's very similar, actually, but it is more validated for Japanese population. Actually, I cannot find difference between both of them. Let us have this question. Considering role of catecholamines in thyroid storm, there is increased availability of adrenergic receptors. It increases the catecholamine, increases thyroid hormone binding to thyroid binding globulin. It stimulates thyroid hormone synthesis. Beta blockers are one of the drugs triggers thyroid storm. Sorry for this. Actually, this is what believed about the pathophysiology, and one of the most believed theories about pathophysiology of having storm is the interrelation between thyroid hormone and catecholamines. In thyroid storm, there is a great availability of adrenergic receptor with reduction of binding of thyroid hormone to its binding protein. It's more free and easy to work. And so the released catecholamines with the stressful event that usually trigger the storm, having a great availability of receptor, so an exaggerated catecholamine response is there. What is the triggers? A lot of triggering. Actually, if I'm not compliant or I am just suddenly stopping the anti-thyroid medications, it might precipitate storm. Having a major surgery, especially if this is a thyroid surgery due to manipulation of the gland, trauma, especially if the neck trauma, it is very much can precipitate pregnancy, labor, infection, of course, having emotional or physical intense emotional or physical stress might have a role. Cerebrovascular disease, thromboembolism, pulmonary thromboembolism, or other triggers can lead to storm. So I can diagnose a storm if I'm having a history of thyroid disease or thyroid treatment or suggestive history like our case, if I'm having an exaggerated symptoms and signs of hyperthyroidism, if I'm having a lab like very low or even undetectable TSH and high T3, free T3 and free T4. Symptoms and signs, fever, of course, actually it can up to hyperpyrexia, tremors, delirium, confusion, up to coma, tachycardia, tachyarrhythmia, AF, one of the very common presentation, congestive heart failure, MI, cardiac events, diarrhea, nausea, vomiting. What are the lab abnormalities? Of course, the thyroid profile and the presentation. Hyperglycemia can be like cardiac enzymes and non-STEMI, electrolyte imbalance. Hypokalemia is famous, and there is an entity of thyrotoxicosis induced hypokalemic or periodic hypokalemic paralysis. It's common in Asian population, and it might up to DIC. When I am treating this patient, actually I am targeting the following. I am targeting to support the patient for whatever life-threatening situation. I'm using ABC's approach, airway, breathing, circulation, and so on. So supportive measures. I have to search, identify, and treat the precipitating factor or factors. And of course, I have to limit the presence of high thyroid hormone release. I have to decrease its effect on the peripheral tissue, namely cardiovascular system. And here we can work with adrenergic blockers, beta blockers. And I need to also to decrease or inhibit or even prevent thyroid hormone synthesis, anti-thyroid medication. I need to stop conversion of T4 to T3. So this is where the glucocorticoids work. And again and again, continue our supportive measures. We have to be aware of some warning points here. Beta blocker is the one to start. Propranolol is the best to choose, but you have to be careful with some patient with hyperreactive airway, like our patient with chronic obstructive airway disease, patient with myopathic heart and heart failure. Actually, beta blocker is okay. It will give a benefit, of course, when used cautiously in high output failure precipitated by the stool. But I have to work very carefully in those patients. Even I might go for calcium channel blockers to control heart rate if the patient is like in acute severe asthma or like that. Ismolol is an alternative to propranolol. This is coming in Japanese guidelines, especially. Thionamides or antithyroid medication, especially propylthiouracil. I have to be careful with its liver toxicity. Propylthiouracil is the preferred one because it works on the synthesis, and at the same time it works also on the conversion of T4 to T3 in the peripheral tissue, so it will result in a prompt and very nice reduction in the level of thyroid hormones. Iodine solution, it will prevent release of the hormone from the gland by working on iodide transport mechanism. This should be at least 1 hour after giving the first dose of thionamide, especially for toxic nodular goiter or toxic thyroid adenomas, because otherwise this acting or hyperactive factory will use the iodine that I am giving as a substrate, overcoming the iodide transport, and it will result in worse condition. Coming to the life-saving medications that we are in love in ICU, glucocorticoids, hydrocortisone are the one to be given. Here it will decrease conversion of T4 to T3, and at the same time it work in adrenal to support adrenal. There might be some relative adrenal insufficiency in this overwhelming stressful situation. Having bile salt sequestrants by cholestyramine will prevent the enterohepatic recirculation of thyroid hormone, so it will prevent reabsorption of the hormone again and help to get rid of excess hormone. Of course, don't ever forget the triggers, and don't ever forget supportive therapy. Cooling is one of the most important lines of management. Cooling by cooling mattress and other cooling methods. Antipyretic, be careful about aspirin. It increased level of thyroid hormone through its working with the binding protein. Acetaminophen, also, of course, is the one to be used. Some cases are refractory to treatment, or there is a contraindication for using antithyroid medication, like toxicity or allergy to thyracil or other antithyroid drugs, major adverse effect like hepatic toxicity. Some patients developed storm because they have a problem with the side effects of the antithyroid medication, so they have to stop it, and then they developed storm. In this case, we have to work with beta blockers, glucocorticoids, bile acid sequestrants, and plasma exchange or plasmapheresis was very much helpful in some cases with refractory response or contraindication use of antithyroid medication. It can clear the hormone, and it can clear also the antibodies and other immune complexes if the resultant in Graves' disease, for example, or in some cases reported with agranulocytosis with antithyroid medication. Even thyroid artery embolization, there is some literature speaking about that, and we have to go for emergent thyroidectomy, of course, after a very good preparation of the patient. Preparation, beta blocker, glucocorticoids, antithyroid, or even the plasmapheresis if it's contraindication. It's advised to have the surgery after adjustment of the level of hormones 5 to 7 days, not to delay more than 10 days. It might turn to be worse situation with what's called Wolff-Chekhov escape phenomena. The Logos iodine initially can block the transport mechanism and prevent release of thyroid hormones, but by time and adaptation and feedback mechanism will work, and this iodide transport mechanism can overcome the block, and now the gland can use what we give iodine solution to be a substrate, increasing more and more production of the hormone. This is a summary for the management of thyroid storm. Again and again, it's a multidisciplinary approach as all our problems. We have to work with clinical pharmacists for medication, side effects, and others. And we have also to work with endocrinologists. It's very important. Cover other specialty according to the patient presentation. Now we have to shift to another problem with thyroid gland, with thyroid hypofunction. And let us to go for this question. Myxedema coma associated with high incidence of hypertensive crisis with anxiety, irritability as a cardinal features. It is one of the differential diagnoses in case of hyperpyrexia. It may present with convulsion. Yes, of course, it can, of course, with convulsion, can be the first presentation. Actually, if the storm is the state of hyper or exaggeration, we are in state of hypo or insufficient. Just to have this another real life case, 72 years old female patient found unconscious in her home. Her family gave a history negative to any medical illness or any medication. When she's presented to ER, she was comatose, GCS 3/15. Vitals, she's very much hypoventilated, 6 beats per minute, her respiratory rate, heart rate 40 only beats per minute, temperature 32.7 degrees, her blood pressure 60/40, saturation on room air was not detectable because of this very low blood pressure and others, and also hypothermia. She was immediately intubated on her in this condition, connected to mechanical ventilation, and was put on vasopressors and IV fluid boluses. and she was put on warming blankets. On general examination, her skin was very cold, clammy, scaly. There is generalized edema, non-pitting, especially pre-tibial. Her ECG show low voltage sinus bradycardia with long QT interval. Her labs lactate 2.8, hemoglobin 4.2, serum sodium 123, 12 lead ECG, this bradycardia. CT brain after stabilization, of course, was unremarkable. Sorry for this transition of the picture. Her CT chest shows pericardial effusion. She was, of course, shifted to ICU immediately, continued on vasopressors and other support, mechanical ventilation. She was given empirical antimicrobial therapy as per local protocol, together with continued warming efforts. Pericardiocentesis was done, draining almost 900 ml, but actually this was not associated with improvement of her hemodynamics. Shortly after her admission to ICU, she started to have myoclonic seizures, and patient was put on anticonvulsant, and EEG was planned to be later. Her labs showed the following: TSH 52.45, total T3 less than 0.75, total T4 less than 14. And with the checking with the normal reference, it's very low T3, T4 with very high TSH. CK was very high. She was underwent CSF analysis to check for this coma for infection. It was unremarkable, actually. So in this case, what are the positive findings? We have a patient, female, old female with hypothermia and bradycardia. She is in deep coma, negative CT, negative CSF. She is shocked with pericardial effusion. Tapping of this effusion or pericardiocentesis does not improve the condition. And her thyroid profile was very much characteristic. So what run with myxedema coma in this case? Actually, I can tell she's hypothermic. Other suggestive symptoms of bradycardia, hypoventilation, bradypnea, of course, with the thyroid profile. What I can tell in our case is a trigger. Again, this patient presented for the first time with no history of previous diagnosis of hypothyroidism, no treatment, and she might be stressed. She might be having some infection also. What diagnostic tool? Actually, there is no so much scores regarding myxedema coma. We are depending on the symptoms, clinical pictures, plus lab data. So let us to have some words about myxedema coma. It is rare, fatal, coming in women, usually old. Even with treatment, still it might end badly into mortality. Can be triggered by exposure to cold, by infection and sepsis, by labor, surgery, congestive heart failure, any stressful events. Clinical picture, as we know, the patient might present with coma, convulsion, or even agitation and confusional status. Sometimes, like it was told, like myxedema, madness, hypothermia. It's a very common feature. Generalized edema, the characteristic feature, macroglossia, bradycardia, and other characteristic features. Diagnosis using history, presenting symptoms and signs, and lab values. ECG, echocardiography might trend in pericardial effusion, cardiomegaly, increasing thickness of cardiac walls, and reduced cardiac output. CT brain, of course, to differentiate the situation from other differential diagnoses. What are the treatment? Once more, we have to support the patient to keep her alive. Same like in hyperthyroid or thyroid storm. ABCs again, check for the triggers, especially in hypothyroidism, due to the very common association with adrenal insufficiency. You have to think about adrenal insufficiency while you are thinking about thyroid or myxedema coma. We have to give the hormone, the deficient hormone. We have to give steroid and correct the complication, electrolyte disturbance, and so on. This is a summary for what we told. So thyroid hormone replacement, how to, shall I replace T3 alone, T4 only, both of them, combination of T3, T4? It is an area of controversy, because when you are giving thyroid hormone, you have to be very cautious about the cardiac response. You might increase mortality of the patient because you are overwhelmed the cardiovascular system. One of the one of the agreed techniques to give T3 and T4 with a monitoring. If the patient can be given if we are using an intra route, they can be given through the nasogastric tube, or IV is an alternative route. We have to monitor thyroid hormones. If it's given oral every 1 to 2 days, if it is given intravenous at least 1 hour after the dose, we have to be very cautious, be having a close monitoring of the cardiovascular system, hemodynamics, and other levothyroxine can given as 200 milligram IV, followed by 50 to 100 milligram or microgram per day, followed by associated with T3, 5 to 20 mic IV, followed by 25 mic every 8 hours. Can be oral if the patient can swallow, or through nasogastric tube. We can prepare a solution. That's why clinical pharmacists should be with us. Can be given as a retention enema sometimes. There is opinion about which is more efficient, having it through nasogastric pathway, nasogastric tube, or through the enema, but both can be used. You can agree whatever you want. You can adopt one of the protocols of giving thyroid hormone replacement. Again and again, it's a multidisciplinary approach. Endocrinologists should be available, involved, and a discussion should be carried between intensivist, endocrinologist, and also clinical pharmacist. This is a summary for treatment of hypothyroid coma, myxedema coma. It's multidisciplinary. It is fatal condition. We have to diagnose and treat promptly. Don't ever forget supportive management and searching and treating triggers. There is an entity which is euthyroid 6 syndrome. It is abnormal thyroid profile in patients with no thyroid illness. We can see a lot in our critically ill patients. Usually you have to rely very much on the clinical data. It's again sometimes confusing. TSH here is not that much low. It might be normal or high, normal at least, or not that much low. But again, this might be similar to TSH is not that much elevated. We are in hypothyroid state. This might be a primary, secondary due to pituitary failure, and we have to differentiate depending on the clinical approach, clinical data, clinical presentation. You might go for detecting autoantibody levels to differentiate between primary hypothyroidism or it is thyroid 6 syndrome. It is not an emergency. It is a finding we are seeing a lot in critically ill patients, and it needs discussion and relating the labs to clinical data, and usually there is no need for any treatment. Going to second part of our lecture today is adrenal gland emergencies, going to adrenal hypofunction. Acute adrenal insufficiency is what we will discuss. Let us to have this question. In adrenal crisis, the body is unable to respond to an acute stress. Is an acute status of marked increase of adrenal hormones. It is exclusively a sequelae of Addison disease. There is deficiency of mineralocorticoids activity. Yes, of course, the body is unable to respond to this overwhelmed or stressful situation. Another case, 66 years old male. Actually, when in thyroid you are speaking about ladies, here we can tell it can affect male again. Known to be heavy smoker, hypertensive. He was on 18 hours overseas trip from States to Cairo. He was feeling unwell after his arrival, attributed this to the long journey and jet lag. After his arrival, 2 days after his arrival, while the patient is still complaining of sense of weakness, he was having malaise, low-grade fever, sore throat, non-productive cough, anorexia. He got repeated attacks of vomiting, diarrhea, which was initially treated as gastroenteritis. He used some of OTC's medication, but his condition did not improve. There is more 3 episodes of syncope followed by brief loss of consciousness, so the patient was taken to the nearest hospital. On examination, his temperature 36.4, his heart rate 120, blood pressure 70/45, respiratory rate 30 per minute. His saturation of room air was okay, 99. There is decreased urine output. He was drowsy, generally weak, no focal neurological deficit. His mucous membrane was very dry and his eyes were sunken. His labs showing sodium 117, 117, potassium 6.1, urea 88, creat 2.6, blood sugar 40, and at that time he was given 150 ml of dextrose, 25% for emergency hypoglycemia. During his ICU, he was diagnosed as prerenal acute kidney injury, and this attributed to dehydration, hypotension. So he was well hydrated, blood pressure was managed with vasopressors, cardiac cause by echo was ruled out, there was no cardiac abnormality. Actually, acute kidney injury was improved by labs and clinically, but with no improvement of hypotension, malaise, weakness, and hyponatremia. So as to complete his profile, morning serum cortisol was obtained and it was low. So ACTH stimulation test was performed before administration of hydrocortisone, and also pituitary panel was obtained. His ACTH was low, morning serum cortisone basal was low, and post ACTH stimulation 30 minutes was both less than expected. A further history was taken from the family, and the patient was having attacks of cough, and he was having some skin problem while he was in States, and he was received steroid for both his chest and skin condition. He was like COPD by chest X-ray. This steroid therapy was continued more than 6 or 8 weeks, but the patient, when he was preparing for his trip, he was not that much compliant. He missed 1 or 2 doses in the last week before his trip, and actually he was not taking his medication during this 18-hour flight, and many stops Let us to tell what are the positive findings here. I have a male patient coming with weakness, malaise, anorexia, vomiting, diarrhea. He's hypotensive with dehydration, hypoglycemic, hyponatremic. There is prerenal impairment. He has having low ACTH and low serum cortisol with positive ACTH stimulation test. Let us to check. What runs with adrenal crisis in this case? I can tell symptoms is very suggestive, but actually it can be any other reason. There are 100 causes lead to vomiting, and then shock, dehydration, weakness, gastroenteritis might be a cause. Yeah. But actually we have vomiting, weakness, shock, hyponatremia, hypoglycemia. But what positive here in this case is that the patient was on chronic steroid therapy for almost 8 weeks, and he was not compliant for this treatment in the last few days and the last week because of his drip, because of like his illness. What is the precipitating factor here? It's a sudden stop of chronic steroid therapy. Yes, stress. He might have this productive cough, chest infection, stress, a physical and mental stress of this very long trip. Is there any diagnostic tool? Yes, I have a suggestive symptoms. I have a suggestive signs, lab with low cortisol and ACTH level. And we have to connect. We have a hypothalamus releasing CRF, corticotropin releasing factor, which stimulates anterior pituitary to release ACTH, which in turn stimulate adrenals to release cortisol in response to stress. If I am taking an exogenous steroid chronically, and there will be a negative feedback inhibition on hypothalamus and anterior pituitary to stop, and then on adrenals. Actually, I'm inhibited. My stress response is inhibited. We will speak about Addison disease. Addison disease, it was described first time 1855 by physician Thomas Addison, who also described the pernicious anemia. It was described for the primary adrenal insufficiency. It's a primary adrenal insufficiency. The adrenals were destroyed either by TB, by infection, by tumor, but this and a primary adrenal insufficiency due to failure of adrenal gland. Of course, the introduction of cortisone as a therapy was improving too much the mortality in this disease. Acute adrenal insufficiency, it is a crisis. It's the exaggerated form of adrenal insufficiency, but it can be because of either primary adrenal insufficiency or secondary due to pituitary failure. It's an acute status of severe cortisol and or aldosterone deficiency triggered by any stressful event, surgery, infection, emotional trauma, and again, and severe stress in which the body cannot respond to it properly. And the body is not able to release sufficient cortisol because of the feedback inhibition, in this case, with resultant acute exacerbation of symptoms in the patient might be Addison disease. It will be exaggerated all the time. He will be like our patient presented with acute Addisonian or acute adrenal insufficiency. And these are the causes, acute and chronic causes, which might lead to adrenal insufficiency. And they are triggers again, it's almost the same. And clinical picture, it's hypotension, shock, maybe renal impairment, acute kidney injury, like in our case, together with characteristic hypoglycemia, hyponatremia, and low cortisol level and ACTH. Again, the management is supportive. We have to work with APCs and control the patient's condition that might threaten his or her lives, and searching and correcting the triggers together with giving steroid replacement. the prevention is very important in the patient on chronic steroid therapy, especially if the patient is facing stress like surgery, for example. We have to stratify this severe or mild or moderate stress and to give an extra dose of exogenous steroid for those patients to cover the increasing stress. There is a situation we are facing again in our critically ill patient. It is a critical illness related corticosteroid insufficiency, like in case of sepsis and septic shock. And this is the base for steroid in sepsis, for example, septic shock, like that. And our last point to be discussed in this lecture tonight is adrenal hyperfunction. Actually, I'm going to cover a situation which is really scary. It's a pheochromocytoma crisis. Let us to have this question again regarding pheochromocytoma crisis. It's common cause of hypertensive crisis. There is a marked increase in gonadotrophin hormone. ECMO might be the only solution, usually presented with heart block. Actually, it's not a common cause of hypertensive crisis. It's a rare situation. There are many causes of hypertensive crisis are common, but this is not a common cause. The common here is the problem. It can cause, of course, a hypertensive crisis, and we have to be aware of this cause, because we have to modify the treatment sometimes for this situation. But it's catecholamines, gonadotrophin hormones, where the problem is about catecholamines, but actually extracorporeal membrane oxygenator and extracorporeal support might be the only solution for a patient to save a patient in this situation. It, of course, it does not presented with a heart attack. Let us to proceed. This is a case. Actually, it's not a real life case. This case I quoted from a literature. It's 37 years old female, history of borderline hypertension, underwent elective ANC operation, was vaginal bleeding, menorrhagia. In the recovery room, after uneventful short intraoperative course and full recovery from anesthesia, she suddenly got syncope. There was found in pulse oximetry saturation is 80%. She was connected to oxygen. Blood pressure was measured. It was very high. Oxygen therapy did not improve her saturation, so the patient was intubated immediately. Secondary to severe hypoxia resistant to oxygen therapy non-invasively. And by examination and bedside X-ray, she looks like having acute pulmonary edema. She was pushed to ICU immediately, where the ventilator parameters adjusted to improve oxygenation of the patient. Upon ICU admission, Upon ICU admission, her blood gas is showing severe acidosis, pH 6.8, CO2 51, oxygen 71 millimeter mercury, lactate is 10. She was having hyperlactatemia. And again, ventilator parameters again and again adjusted to provide the best oxygenation for the patient and clearance of carbon dioxide. So sedation and muscle relaxation were used. For controlling of this high blood pressure, so we are in hypertensive emergencies, nitroglycerin infusion started, diuretics, and with close control monitoring of blood pressure. Temperature was 37.9, heart rate 150, cardiac auscultation. There is a gallop rhythm. There was diffuse rails all over the chest. 12 lead ECG, sinus tachycardia. There was no significant ST segment changes. Chest X-ray showing pulmonary edema. Transthoracic echocardiography showed global hypokinesia, biventricular dysfunction. LV ejection fraction 25%. Cardiac troponin was over the normal. It was considered that the patient is having toxicity mostly related to catecholamines, and this when it was considered in the diagnosis. The family was questioned further for any clue for her condition. They gave a history of 12-month history of recurrent episodes of palpitation, diaphoresis, and headache. With this history, the team thought about pheochromocytoma. They requested 24-hour urinary vinyl mandelic acid. It was high, and urinary catecholamine was very much high. So diagnosis was made as hypertensive emergency due to pheochromocytoma together with acute pulmonary edema, cardiomyopathy, and hypertensive encephalopathy, as the patient's consciousness was also affected. CT abdomen was decided, but actually the patient was completely unstable to be moved to CT department. So ultrasound was requested. It can show the right adrenal mass. It's a very big mass with cystic change, solid with some cystic changes. During her ICU stay, the patient received control of her blood pressure, phentolamine infusion, together with nitroglycerin for better control of her blood pressure, and of course to achieve alpha blockade after diagnosing the pheochromocytoma. Oxygenation was not improved even with all efforts to adjust the ventilator. Blood pressure initially it was resistant, then become very labile and high and low. Later on the fourth day, blood pressure continued to drop. So all antihypertensive medication were stopped, and monitored fluid challenges were given. So we can give fluid without being overloading the patient. And later on, vasopressor with levofed started. Hypoxia was refractory and no improvement in hemodynamics. ECMO was the solution decided. Actually, unfortunately, this patient did not receive ECMO because it was not available in her this center, and communication done to transfer her to ECMO center. Unfortunately, this was not ever done. Circulatory collapse continued. Response to increased doses of vasopressors and inotropes later on. Refractory circulatory and respiratory failure leads to cardiac arrest, and patient declared dead on the day 6 of her presentation. A very sad story in this one. But again, what are the positive findings in this case? We have a hypertensive crisis, we have pulmonary edema, we have a suggestive history that what about the episodes of high blood pressure, diaphoresis, palpitation, and cardiomyopathy, encephalopathy, increasing catecholamines in urine, and ultrasound finding of this adrenal mass. Actually, ultrasound is not the gold standard for diagnosis. CT is the best, but it's not always feasible to take the patient out of the ICU. So what run with the pheochromocytoma crisis in our case? Hypertensive crisis, tachycardia, cardiomyopathy, suggestive history, lab data. What is the precipitating factor for this crisis? Looks the patient is suffering of pheochromocytoma. She was not diagnosed and she was not treated. Surgery and anesthesia, they are known to have to precipitate pheochromocytoma. Either in diagnostic tool, the clinical presentation plus labs, imaging to diagnose adrenal as the cause of this exaggerated catecholamine release, CT or MRI. So again, pheochromocytoma is an uncommon endocrine tumor of chromaffin cell of adrenal medulla. This is the most common place of this tumor, but other places are very much less common. Chromaffin cells produce, store, and secrete catecholamine, and all presentation clinical pictures of pheochromocytoma attributed to excessive catecholamine release. The presentation is variable. It might be silent, diagnosed by luck, or characteristic signs and symptoms, or maybe like our case, maybe the first presentation at the crisis. It's endocrine emergency, significantly high mortality. Of course, there is end organ damage and hemodynamic instability. If well treated, it can be reversible. These are types of clinical presentation pheochromocytoma, either asymptomatic or symptomatic, the usual, or a crisis. We can identify two types of crisis. This is type A with hemodynamic instability and organ damage or dysfunction. One organ at least there is damage. Type B is extensive crisis with shock. In type A, the blood pressure is very high, and type B, we are in hypotensive shock state, of course, multi-organ dysfunction again. These are the clinical spectrum: cardiac, respiratory, neurological, renal, hepatic. Almost all organs can be affected. A precipitating factor, again, no treatment, insufficient treatment. Trauma to the abdomen, to the adrenals, to the tumor itself, either surgical or it might be physical trauma or surgical trauma. During biopsy can be general anesthesia, surgery, intubation. Some drugs can lead to crisis. Common diagnostic dilemmas here. This presentation can simulate acute coronary syndrome, cardiomyopathy, cardiogenic shock, septic shock, preeclampsia. Pathophysiology is there is an excessive catecholamine with profound arterial vasoconstriction, tissue ischemia, and if we are in shock and sustained hypotension, we are in type B, and this excessive beta-2 receptor stimulation with excessive vasodilatation and some tumor with adrenaline, especially adrenaline. When to suspect pheochromocytoma crisis, unexplained shock, multi-organ failure. This shock is not corrected even with correction of many factors, but history, of course, unexplained lactic acidosis. Actually, it's a rare condition, so we have to keep it in mind not to miss. What is the management? The usual supportive emergent resuscitation management, ABCs, fluid and vasopressors if needed, inotropic support if needed, mechanical circulatory support might have a very important role. For controlling your blood pressure, we have to think about alpha blocker first. After good blocking of alpha receptor, we have to think about going with beta blocker. Calcium channel blockers as alternative. Magnesium sulfate, same like where we are in preeclampsia. Or direct vasodilator agents, again combined blockade using more than one antihypertensive medication. Beta blocker should not be used prior to alpha blocker. This is a rule. A low dose of short-acting beta blocker like osmolol with careful monitoring is very much preferable. Labetalol, better to be avoided because the ratio of alpha to beta is not very much same for every patient. It's better to use alpha blocker pure first, then after blocking alpha receptor, we will go for beta blockers. For hypotension in type B or advanced type A pheochromocytoma crisis, fluid management, monitored of course, vasopressors, inotropes, intra-aortic balloon, and ECMO might be the only solution. Surgery should be like in thyroid storm, we should postpone surgery until the condition is stabilized. If the patient very unstable, medical stabilization has failed, we might go for emergency surgery to carry a very high risk of mortality. Laparoscopic, of course, is much preferred than open surgery. So for today, we finished a heavy subject. Actually, we not finish. We just highlight the important points. What we have to remember after finishing this lecture today, this night, actually ABCs, we have to thank ABCs. We have to, when we are seeing a critically ill patient, we have to support him or her. We have to manage what can kill the patient, and then to think about specific therapy. Multidisciplinary approach is the key in our critically ill patient. It's a guarantee success in emergencies. Always think in rares. Rares you have to keep in our minds, not to overlook. And especially if the response is not the scenarios, always search for a trigger. Always search, identify, and treat triggers. Vomiting and diarrhea are not always gastroenteritis. There are many very fatal causes presented with vomiting and diarrhea. Serum glucose should be checked for any unstable patient, actually any unstable patient, those with altered mentation. Steroids are our loved medications, are life-saving. Thank you very much.
Perfect. Thanks very much, Prof. Salwa. I'll just put the poll here to document attendance while we're discussing here. So I got a nice question from Tariq Abdel Maqsood, and I think it will be the only question for tonight because it's 10 o'clock here and 11 o'clock in Cairo. We are a bit, like, I know it's a huge amount of teaching tonight. Thanks for all attendees that were patient with us until now. So Tariq Abdel Maqsood is asking, what's the safe medications if you are intubating a patient who is presenting in emergency department with mixed edema coma? He's talking about IV induction agents and muscle relaxant, given the fact that this patient is usually hypotensive, bradycardia, and sometimes he's presenting with seizures or convulsions. What do you think?
Actually, I can tell it's the same for any unstable patient that we are intubating. Use titration of different agents, so avoid suppression of hemodynamics. I'm using fentanyl for myself, titration together with my benzodiazepine sometimes. Be careful. Even propofol, but we have to be very cautious. We have to properly monitor the patient because we might go into cardiac arrest while we are inducing the patient into for intubation. This is a Dr. Sameh recommendation. Dr. Sameh Salim, my dear friend and professor, he is always telling, be careful, you might need to insert an arterial cannula before going to intubate a patient who is critically ill. You might face a cardiac arrest while you are intubating the patient. Start your support, start your vasopressors, start your fluid bolus, and go for intubation with a titrating dose the patient, titrating again and again. And assess for, of course, for difficulty in intubation. It's a very difficult while you are ER or an ICU managing critically ill. Difficulty. So if you are using, think about succinylcholine or think about shorter acting non-depolarizing muscle relaxant if you are having renal problems with this patient. Better to avoid, use sedation with a titration and keep monitoring your patient.
If you allow me, Prof. Salwa, we may think in advance. So if the problem is mainly bradycardia, you may give some glycopyrrolate 200 to 400 microgram in advance of your heart rate suppressing medications. You may use, if it's not rapid sequence induction, you may use the pancuronium, the same policy we are using in cardiac anesthetics to offset the bradycardic effect of your fentanyl and narcotics and other drugs. So think in advance. You may use some salbutamol or Ventolin NEPs to increase the heart rate before you intubate. So make use of side effect of certain drugs to make that happen. And I am stressing on the point you said a minute ago, like we need an arterial line monitoring heart beat to beat variation in the blood pressure recording. And you can prepare the dobutamine, the NORAD in advance if you have time for that. If it is just an emergency and you don't have the time, deal with it as an emergency case. Again, atropine is and adrenaline are your first drug of choice in these occasions, if you agree with me, Professor.
I, of course, agreeing with you. Even transcutaneous pacing might be a very helpful in ER for the patient with severe bradycardia or heart block. It is a life-saving, of course. You be ready with all emergency medication. Agreeing 100%.
Perfect. So the last thing here we want to say is thanks very much for your attendance. We started with 230. Until the last minute, we have been 210, almost 210 attendees. So thanks for your patience tonight. It was lovely lectures from eminent speakers. My full appreciation for the speakers and the attendees, and see you next Saturday, 9 p.m. Cairo time, as usual, with the week number 16, and keep monitoring the page. There is some modifications in the coming schedule, how you pronounce it. So we have on 10th of October one of the eminent professors from Saudi Arabia. He is Professor Abdulaziz Boker, and he's talking about an area I need every professor in Egypt attend this lecture. Actually, it is the impact of simulation on anesthetic practice and anesthetic training. Professor Abdulaziz Boker is one of the eminent professors in the whole Middle East in this area, so I would recommend you must attend, particularly if you are practicing teaching and training, coaching in your college or your faculty of medicine. For now, thanks very much, my full appreciation again, and see you next Saturday, inshallah. Thanks very much. See you. Bye.
Thank you very much. Bye-bye.